This is Unit 5A. Joints or articulations are the sites of meeting points of two or more bones, and they function as they allow for skeletal mobility, and they also hold the skeleton together. They are the weakest parts of the skeleton. Most injuries to the skeleton actually occur at the joints. The classification of joints can either be done on the basis of function or structural characteristics. The functional classification, there are three classes: immovable, slightly movable, and freely movable joints. These are synarthroses, amphiarthroses, and diarthroses, and they are all based on the movement or amount of movement allowed by the joints. So syn, amphi, and diarthroses. These are terms that don't exactly, I'm not, freely familiar with always, and I really always have to look them up. Maybe they are of more interest to some of you, I'm not sure, or maybe you have some experience with terms for joints. I'll focus mostly on the structural classes of joints, and that's how I'll describe the different joint types. And I'll spend a little extra time on the joints in the rib cage, and also maybe disease processes in joints. The classification of joints on the basis of structure depends on the material that binds the bones together at the joint, and also whether there's a joint cavity around the joint or not. The three structural classifications are fibrous, cartilaginous, or synovial, and it's the synovial joint that has a joint cavity. So the fibrous structural joints are held together by fibrous connective tissue. There's no joint cavity around, or space, enclosed space around the joint, no joint cavity, and most of these types of joints are immovable. There are three types of fibrous joints: sutures, syndesmoses, and gomphoses. Again, as you can see, these aren't terms that we usually come across or hear very often, at least I don't. Sutures, syndesmoses, gomphoses. I'll describe each one. The sutures, the first type of fibrous structural joint, occur between the bones in the skull. These are interlocking junctions filled with connective tissue fiber. So there's quite dense fibrous tissue in between fibrous connective tissue. This binds the bones tightly together, but from the time the child is born until it reaches I guess early to mid-teens, there's still some growth. By the time a person is in middle age, these skull bones are completely fused and are then called synostoses. I'm not going to ask you that kind of a term, synostoses, but in any case, the skull bones have to be flexible, while especially in a very young infant, they are extremely flexible, and there's actually a space at the front of the skull in a where there's no bone, so that the brain is still expanding in size somewhat. But eventually these sutures get connected, and eventually they're connected very tightly. They're fused, and eventually. The second type of fibrous structural joint. This number 1 here refers to the fact that it's the first of the 3 types, fibrous, cartilaginous, or synovial classifications on the basis of structure. The second type of fibrous structural joint are the syndesmoses, which allow some movement, anywhere from some movement to completely immovable. So functionally they vary somewhat. They are connected, as I said, by fibrous tissue. In fact, it's a ligament. Ligaments, by the way, I just should mention this at this point. Ligaments, I want to emphasize, join bone to bone, and here you can see an example of that between the fibula and the tibia at the base of the at the bottom of the leg. At the bottom of the lower leg, you have a ligament. Ligaments join bone to bone. Tendons join bone, muscle to bone. All right, that's an important distinction. The difference between tendons and ligaments is that tendons join muscle to bone and ligaments join bone to bone. Examples of syndesmoses, fibrous tissue ligaments connecting bones are found in the tibia and the fibula, and also in the radius and ulna of the lower arm. And then the third type is the gomphoses, the third type of fibrous structural joint. This is a peg and socket type of fibrous joint found between the tooth and the socket, the tooth socket. There's a fibrous connection, which is a ligament. It's called the periodontal ligament. So the second structural classification of joints is cartilaginous. The bones that meet at the joint are connected by cartilage as opposed to fibrous tissue. They don't have a joint cavity, just as the fibrous structural joints don't. There are 2 types of cartilaginous joints. There's the synchondroses and the symphyses. And these are as follows. Synchondroses, it's a bar or plate of hyaline cartilage that unites bones. They're all immovable, all of these. And the typical example would be the epiphyseal plate that's found in the long bones of children. But also the joint between the first rib and the sternum is also a synchondroses, an example of a bar or plate of hyaline cartilage joining bone to bone. So here you see an example. The example shown here is there are 2 examples of the synchondroses, cartilaginous joints, synchondroses type of cartilaginous joints. Here what you see is called the epiphyseal plate. That's something that you should understand. Long bones found in the arms and in the hands and in the legs and in the feet grow in length in children, and the only way that they can grow is if they have a region, and they do have that region at the end of the bone, shown here in this diagram, which contains hyaline cartilage, and on either side new bone tissue is being laid down, new bone matrix material. So new bony tissue is being formed on either side of the epiphyseal plate. Epiphyseal plate is the area where bone grows so that a long bone can grow in length. Very evident on x-rays in kids, because it's not radio opaque like bone. It's made of cartilage in the middle, so you see it as a blank area on the x-ray, as opposed to an opaque. It's a black area as opposed to an opaque, a clear area that you can see through. And as the child gets older and stops growing in height and their bones stop growing in length, the epiphyseal plate finally ends up being replaced completely by bone tissue. The other example of synchondrosis, a cartilaginous joint, is between the first rib and the sternum. And I point out to you here that the first rib, that we have 12 pairs of ribs between where the ribs meet the sternum. That first joint is a immovable type of cartilaginous joint or synchondrosis. The rest of the joints of the ribs, the other, at least the other, of the first 10 ribs going from the top down, so from the superiormost to the inferiormost of the 12 pairs of ribs, the first one has this kind of joint, and then the next 10 have a different type of joint, and we'll look at those later. They have synovial plane joints. And then the last two pairs of ribs, of course, the 11th and 12th pair of ribs are floating ribs with no joint connecting them to the sternum, no joint at all. There's no connection to the sternum at all. Now another type of cartilaginous joint, the other type is symphyses. Here you have hyaline cartilage covering the, and the example is between vertebrae. It's covering the articulating surface of bone and is fused to a pad of fibrin cartilage that lies in between the two bones. These are slightly movable joints. The term for slightly movable is an amphiarthrotic joint. And examples again would be the intervertebral joints, also the pubic symphysis, the pubic bone, and the pelvis. The third type of functional joint we did first was fibrous, second was cartilaginous. The third type is a synovial structural joint, which is much more complicated because of that surrounding joint cavity. In these type of joints, the bones are separated by are in a separate joint cavity that's filled with fluid to increase the reduce resistance to movement. The fluid helps, it's synovial fluid. It helps lubricate the joint essentially. There are 6 kinds of synovial joints. I will not ask you the names of these 6, but there are 6, and they are based on the shape of the joint and the type of movement. There is one I would want you to know certainly, which is the plane type of synovial joint that's found in association with the 2nd to the 10th pair of ribs, and ball and socket, which is found with in the shoulder and in the hips. And in fact, overall, most of the joints in the body fall into these 6 categories here. Now we're going to look at them. They're quite complicated structures, and we'll go through each one just to give you an idea. But I would not ask you, like, for example, the type of joint structure you find at the knee is or in the shoulder socket is incredibly complicated. You'll see. Here's the plane type of synovial joint, which is found in association with the 2nd to the 10th pair of ribs. Remember, the last 2 are floating ribs. They're not attached at all to the sternum. These are essentially flat surfaces. That's why it's called a plane type of joint. They only allow for slipping or gliding type of movements. And this is the classic example, the sternocostal ribs for ribs 2 to 10, rib pairs 2 to 10, but also you find it here in the hand, here at the base of the thumb. So that's something that I certainly would expect you to know. The hinge type of joint is shown here. It's the kind at the knee or elbow or between the bones and the fingers, the interphalangeal joints. You get movement on a single plane. So these type of joints are synovial. There is a joint capsule around the joint, but they're also part of the classification is also the type of movement based on the shape of how the bones join to each other. The pivot joint, and the details are here. I'm not going to go into that much on it. This is the condyloid or ellipsoid type of joint found in the fingers. This is here the saddle type of joint, and here we have the ball and socket joint. And for the ball and socket joint, what you have is that you have a spherical head on one bone, and it articulates or joins at the joint with a cup-like socket on the other one. This kind of joint, a ball and socket synovial joint, allows for almost completely free movement around the synovial, within the synovial joint. It's found at the shoulder and the hips. I might have said the knee. It's not the one at the knee. It's the shoulder and hips for ball and socket. I should point out that these, the hips certainly, hip joints are now very commonly replaced with artificial joints, but they're also now doing more frequently shoulder joints. I should tell you, for your own information, the shoulder joint is done quite often in a reversed ball and socket. The artificial parts of the joint, the joint replacement of the shoulder, puts a ball in where the socket was and a socket where the ball of this part here was. So it reverses this ball and socket orientation in the artificial joint. Synovial structural joints are, as I told you, contained within a joint cavity which is fluid filled. And the 6 types are shown in the 6 previous slides. But the general structure, and we're going to go through this because the general overall structural characteristics are things that you should know about synovial joints. They are made of articular cartilage. There is a joint cavity or synovial cavity. There's also a articular capsule around the outside. The articular cartilage is found on the inner surfaces. Cartilage is a very smooth, rubbery, articular cartilage is a very smooth, rubbery kind of material that allows the bones to slide past each other as they move. It's the kind of thing that you find at the end of the chicken bones from legs. So it's a rubbery material that allows for nice movement, surrounded by a space or cavity that's fluid filled, and then around all of that a capsule and the synovial fluid. And it has these type of joints, particularly a joint like the knee, has many different reinforcing ligaments joining bone to bone. It's quite complicated. So these are the 5 key structural characteristics of a joint. The fact that on its inner surfaces where bones meet, there is articular cartilage. the fact that there's a space, a joint cavity, also called the synovial cavity. There's a surrounding articular capsule. The joint cavity is filled with synovial fluid, and there are around the whole structure, there can be quite a few different reinforcing ligaments. Here you see a very simplified diagram of a structure, of the general structure of a synovial joint. This is the kind of thing that you would see in, I guess, the knee, whereas here what you see is, I believe, a shoulder joint on the right. But the overall main key parts, the 5 main key parts, I believe, are all shown here. The structure of the joint, inside it contains articular cartilage, which is hyaline type of cartilage on the surface to allow for very smooth surface so the bones can move against each other and not grind against each other. There is a joint cavity containing synovial fluid. There is also a surrounding articular capsule. And the surrounding capsule has a fibrous exterior capsule, and then inside the joint surface, the inner surface of the joint cavity, there's what's called a synovial membrane. All that's part of the articular capsule. And there are ligaments. They're showing one. There can be many. So ligaments, joint cavity, synovial fluid, articular cartilage, and articular capsule. 5 key general structural characteristics of a synovial joint. You know, the synovial joint is essentially a friction-reducing structure. And part of that reduction of friction involves bursa. These are flattened sacs that are filled with synovial fluid, and the fluid is within a space that's surrounded by a synovial membrane. So you have a fibrous sac with the inner surface lined with the synovial membrane, and inside of that the synovial fluid. And these help to reduce friction. They're commonly found wherever you might have ligaments, muscles, skin, tendons, or bones might rub against each other. And I'll show you some diagrams where the bursa are shown. You also have these elongated, instead of a bursa in a sac-like structure, you also have some bursa that are elongated types of sacs completely wrapped around tendons, and that's called a tendon sheath. Okay, that's not called a bursa. Even though it is a type of bursa, it is called a tendon sheath. And here you see that kind of structure shown in the. This is a shoulder joint because that's the humerus, the upper arm, the bone in the upper arm. And here you see a bursa, which is a friction-reducing structure. And here you see a tendon sheath, also in green, another type of bursa around the tendon here. And these are notable in that sometimes they become inflamed, and that is called, and some of you may be familiar with this term, that is inflammation in a bursa is not surprisingly called bursitis. It can be quite painful, and as is characteristic of inflammation, it causes a loss of function. The person will not use the joint, or they'll have limited use of the joint, limited range of motion, and it can be extremely painful. Well, the synovial joints um, offer a certain amount of stability, and the surfaces, the articular surfaces within the joint, determine the shape of them determines what movements are possible, and the ligaments they hold the bones together, they connect the bones, and the ligaments are structures that really prevent excess movement in a undesired direction. Okay, so that's what's preventing your knee from going out sideways, your lower leg from turning sideways for 90 degrees, for example, either outwards or inwards, or moving the other way, forwards at the joint. So you have these articular surfaces with a particular shape, and you have ligaments. All of this provides stability. And you also have muscles with tendons attached to the bones that cross over the joint. So for example, if you may not be aware of this, but for example, your biceps muscle, the large muscle on the anterior surface of your humerus, your upper arm, the biceps is attached to your lower arm by a tendon that crosses the joint at your elbow, the synovial joint at your elbow. So your tendons for the muscles are going to cross over a joint typically and act as a stabilizing force and allow for movement of the around the joint. Muscle tone is important. I remind you that muscle tone refers to a partial state of contraction. It acts as a stabilizing factor so that the tendons have some tightness at all times due to that muscle tone, and you can relax further or tighten up the muscle further, pulling on the bone on the other side of the joint. In terms of movement around synovial joints, you have different types of muscle attachment points across a joint. So when two bones come together and there's a joint, a synovial joint, what you have is one bone will be immovable and the other will be movable. For example, at the elbow, the lower arm is the movable bone and the upper arm is the immovable bone. So the attachment of a muscle, the point of attachment of a muscle to the immovable bone is called the origin, and the point of attachment to the movable bone is the insertion point. So if we're talking about the elbow, the attachment of the bicep, the origin is attached to the muscle, is attached through a tendon to the through the origin to the immovable upper arm, and then attached through the insertion point at to the movable lower bone. Now you can have all kinds of movements along any of the three different types of planes in the 3 dimensions, X, Y, or Z, where Z comes forward. If this is coming towards you, this is left to right, this is up and down, and this direction would be behind the slide, and this would be in front of the slide, coming out front. So you can have movement along any of these planes depending upon the joint, and different joints have different types of movements. For example, your knee can move back but not posteriorly. The lower leg can move posteriorly but not to the front anteriorly. So range of motion is something to consider always. These are terms for the describing the amount or range of motion, whether it's and it refers to the axes that I just drew, for example. The axes are the different directions determined by the 3 plates. So non-axial is just slipping, gliding. Uniaxial is in one plane. It could be any of the planes that I described. One plane. Bi is 2, and multi is all 3. At the shoulder synovial joint, it would be in all 3 directions. Okay, so in terms of range of motion, as we were just discussing, introduced in the previous slide, in terms of gliding movements, that's the kind of, and these we're discussing here, synovial joints. So gliding movements are the kind you find with the plane type of synovial joint, and those are the ones that are found at the sternocostal joints. These are synovial joints. This is sternocostal joints between the sternum and ribs rib pairs 2 to 10. They're also found in the hands, intercarpal, and in the toes, in the feet, intertarsal joints between the vertebrae as well. There's a number of different types of movement. It's worth knowing these. I would not ask you to describe each one, but I think it's worth knowing. And there are images shown in the next few slides that cover each of these, so you can look at those on your own. Flexion is bending or movement that decreases the angle of a joint. That's when you flex your upper arm muscle, your biceps muscle, for example, by bending your arm at the elbow. That's flexing. Extending is the reverse. You increase the angle, so that's extension. Dorsiflexion is up or down movement of a foot, for example, where you're going in the dorsal direction, and if you go down, it's the plantar direction or plantar flexion, so dorsiflexion and plantar flexion. There's a difference between moving away from the midline and towards the midline, and you can do that kind of movement with your foot. At the ankle, you can roll your foot outwards away from the midline, or that's abduction, or towards the midline, that's adduction. Or you can, move your some joints, for example, in a cone shape in space, that's circumduction. And here we see examples of a gliding type of movement. This is flexion, in this case, of the upper of the joint, using the upper leg muscle. Contracting the upper leg muscle will cause flexion, and relaxing is extension. Here you have, hyperextension. Here you have dorsiflexion, raising the foot up because it's the dorsal side of the foot is going up. Dorsiflexion, when you put your foot downwards, point your toes down, it's tarsiflexion. Abduction, you're going away. Adduction, you're going towards the midline being right down the middle of the person here, right? And here is circumduction, when you're forming a cone shape in space. There are all kinds of movements. Here's rotation, special movements, supination, pronation. All of these I will not ask you. However, you should just go through them so you have some familiarity, that you have exposed yourself to these. And that's all I'm going to say here for special movements. There is extra information here on slides 43 to 56. It's included just again for your own information. I wouldn't examine you on it. That is except for the items underlined on slide 45. This here is slide 42. And what the next few diagrams show is structure of the knee, which is quite complex. It's amazing how quickly they can do a knee replacement. They can do knee replacement surgery in an hour and a half, taking out all the structures and replacing them with much simpler components. It's orthopedic surgery is astounding, really. But here is a diagram showing the knee ligaments, bone-to-bone ligaments, and muscle-to-bone tendons, and you can see just how complicated it is. This is slide 45, and what I wanted to emphasize to you are the structures that are called meniscus. Plural would be menisci with the I instead of a US. These are just flat pads within the joint, flat rounded pads. You can see one here. That's a meniscus. It just provides a surface for the cartilage to rotate on and move on. Often, the reason I emphasize this is because it's often damaged inside a joint. It can get torn and cause problems within the joint. The other thing that's shown here that's again underlined and that I would want you to know is the anterior cruciate ligament, or ACL. This is the ligament that's most commonly torn in athletes as they're running and turning quickly, pivoting and turning. They tend to, if there is an injury within the joint in terms of tearing ligaments, it's going to often most commonly be the anterior cruciate ligament that gets torn. Ligaments do not heal easily at all. They need, if it's completely torn, then they'll go in and have to tie it back together. I don't know what system they use, but they'll have to reattach the structure back. It will not heal on its own. More details about the ligaments and tendons at the knee, very, very complicated. This is the shoulder, and you can see the bursa associated with the shoulder. There's a bursa, and there's a bursa, and this is a tendon sheath, a tendon sheath. That is also a bursa, but it's an extended, elongated bursa around the tendon, joining muscle to bone. You can look at each of these on your own, but I'm certainly not going to ask you these terms of the structures here in the anatomy. Here you have bursa at the tendon, at the elbow. Also can suffer from bursitis here commonly. Shoulder bursitis is quite a common occurrence. Here are some of the ligaments. Now, let's talk about structural injury to joints. A typical injury that can occur, and it can be quite painful and cause quite a bit of inflammation, so that you get a lot of swelling, edema at the joint, is a sprain. A sprain is involving the ligaments. The ligaments around the joint are either stretched or torn in this case. And as I told you, ligaments do not repair easily. Partially torn ligaments will slowly repair themselves. It takes a great deal of patience and a great deal of time, but completely torn ones have to be surgically repaired, and usually they do the surgery right away, so there's more chance of a better healing process going on. Cartilage injury, as opposed to sprain, is a common type of injury in aerobic exercise. It can be repaired with arthroscopic surgery. Arthroscopic surgery involves putting a scope into a joint. And the scope is attached to a, what would be the right word? It's like a cable. And they can put it into the joint. They may just make a small hole and put it into the joint, and then they can feed into the cable, tools like to see or to see and cut and extract tissue that they cut away. If they can do all kinds of amazing repairs just using this kind of tube structure. It's quite astounding. Okay, so that's a cartilaginous type of injury as opposed to a sprain, which involves the ligaments. Dislocations occur when the bone is completely forced out of alignment from where it should be in the joint. This is usually accompanied by sprains where the ligaments are, stretched or injured. And inflammation, and often you get immobilization of the joint. It won't work at all. Serious falls can result in a dislocated shoulder because of a fall pushing the humerus out of the joint. These are common sports types of injuries. Partial dislocation is called a subluxation. It's a partial movement of the pulling out from the joint, not a full dislocation. There are a number of different inflammatory or degenerative conditions. I've already mentioned bursitis to you, which is an inflammatory condition in a bursa. And it's usually it can be caused by a blow or too much friction in the joint. Symptoms are pain and swelling, and can be treated with anti-inflammatory drugs or any accumulated fluid. Remember that you should know, I would hope, that there are 4 cardinal signs of inflammation. One being, I'll go through them, one of them being swelling or edema. Another one would be redness. Another would be heat, and the fourth one would be pain. And these are the 4 cardinal signs of inflammation. Also, there's a 5th one, which was actually described a little later after these, edema. It's an A. The 5th one is loss of function, which typically accompanies the other characteristic signs of inflammation, loss of function. The person's not going to use it because it's too painful, or they actually can't use the joint at all. So inflammation around joints is quite a problem, and one of the inflammatory processes that occurs is bursitis. And it can be treated with anti-inflammatory drugs, and if so often there's a accumulation of fluid or edema, and that can be removed, pulled out, or using a needle, so it can be aspirated, and that sometimes improves things. Occasionally they'll use corticosteroids, but you cannot receive, and it's, people describe it as a miraculous improvement, a loss, in terms of the pain and function, ability to use the joint. But you can't give corticosteroid injections into a joint more than once. I think, I'm not sure, but I doubt it would be more than once a year. Otherwise, you get problems with it can cause more damage than healing. Another type of inflammatory process around the joint is tendinitis. And this is really the inflammation of the tendon sheath, which is a type of elongated bursa, as I've told you. Very similar in the end to bursitis. Arthritis, there are many different degenerative or inflammatory diseases in the joints, but arthritis is the most common, most widespread type of disease process in the joint. There are 3 common chronic types of arthritis. Any acute type, sudden onset type of arthritic pain and inflammatory disease is typically caused by bacteria, not very common, treated with antibiotics. But the 3, and this is an acute form of arthritis, is not common. It's fairly rare that you get a bacterial infection in a joint. But there are 3 chronic types of arthritic disease found in joints, quite common. In fact, anyone who reaches any advanced age, and sometimes it's earlier, will have some osteoarthritis. That is the wear and tear kind of, due to constant use over the years, that you get an inflammation within the joint, often associated with loss of cartilage tissue, cartilaginous tissue, the articular cartilage. Another type, which is kind of an autoimmune type of response disease process, is rheumatoid arthritis, which can be very serious. And the third common chronic type of arthritis is gouty arthritis. Also, this process is also called more simply just gout. And it's not uncommon and quite painful. I'll talk about each of these in the next 3 slides, I believe. In terms of osteoarthritis, as I said, it's the most common type of chronic arthritis. Affects more women than men, can be in more than one joint, and with aging it certainly is contributes to loss of the freedom of movement, and people slow down. A lot of it is because of the pain that they feel in their joints. In terms of, associated with age, as I said, almost everyone, in fact, it's about 85 in the United States, that's the statistics I have, 85% will, if they live long enough, certainly will develop osteoarthritis. So it's the most prevalent in age, but it can also be in younger people, but it's probably simply related to the normal aging process, and that's how it's viewed. The course involves, damage due to years of use of the joint, and abrasion, compression. The cartilage gets destroyed, and it's not replaced quickly. It's not a very self-healing tissue. In the end, the bone is uncovered. The end of the bone is present, and you have enlarging and bone spurs and restriction of movement. The joints that are typically affected are in the cervical and lumbar spine, between the vertebrae and the fingers, knuckles, knees, hips, shoulder. It's all, it's a problem. Osteoarthritis is slow and irreversible. Treatments are mild pain relievers, non-steroidal anti-inflammatory drugs, NSAIDs. Moderate or regular exercise is very helpful because it strengthens the muscles around the joint and helps with increasing mobility and a range of motion around the joint. The anti-inflammatories can decrease pain and inflammation and therefore improve, but it's symptom treatment. There's no cure. The only cure is, in the end, you can have the joint replaced. If it's a knee or a hip or shoulder, the joint can be replaced, which is not a small surgery. Therapies that have absolutely nothing to provide, they are completely hocus pocus, include magnets, copper, colonics, that's an enema, glucosamine, there's one that's very popular and completely hopeless, although some people may claim it's not. It's never been shown to be actually have glucosamines any useful effect when scientifically carefully studied. The second type of chronic, commonly occurring, not as common as osteoarthritis, is rheumatoid arthritis. Again, as I said, it's an autoimmune disease, unknown cause. The onset can be quite insidious. It can be, it can come on with some unusual symptoms. Cardiovascular problems can occur first, anemias, and then only later joint tenderness or problems, osteoporosis. So the onset is quite unusual for a disease that in the end is certainly affecting joints. The course of rheumatoid arthritis is marked with periods where it gets worse, exacerbations, or periods where it's seems to go away. There's remissions, but it goes back and forth and steadily can get worse with age. Usually first appearing in age 40 to 50, but can occur in young people also. Rheumatoid arthritis often begins in the joint with a synovitis, so the synovial membrane becomes inflamed. And what happens is that molecules that the body produces during the inflammatory process are inappropriately released into the joint, and you get migration into the joint of inflammatory blood cells that cause swelling, and the synovial membrane thickens. It thickens quite dramatically. This diagram here shows on the left side a completely normal joint, a diagram showing a completely normal joint, and on the right side a a rheumatoid arthritic joint. And what you get is that the synovial membrane thickens quite significantly into what's called a pannus. All the area here, I'm going to darken it in, all that area is what is known as a pannus. This is a characteristic feature, characteristic of the disease process. The pannus erodes the cartilage in the joint. You get formation of scar tissue, and the actual ends of the articulating bones will connect to each other through that pannus. The end result can be, if you see someone with very deformed, bent fingers, it can be, quite crippling. The treatment, there are conservative treatments like aspirin as an anti-inflammatory, or sometimes long-term use of antibiotics, physical therapy. There are more progressive types of treatments with more advanced types of anti-inflammatory drugs or immunosuppressive drugs, because I told you it is an autoimmune disease. Quite a seemingly effective drug, although it may have side effects, so it is carefully monitored. When used is a monoclonal antibody against a inflammatory molecule produced by the body called TNF, or tumor necrosis factor. This is a normal inflammatory molecule that inflammatory cells use to kill invading microorganisms, bacteria, for example. But this antibody will neutralize, and unfortunately, it is produced during rheumatoid arthritis. So the antibody treatment has been shown to be quite effective. This monoclonal antibody, an example of a drug that is this kind of monoclonal antibody. There are now a few companies, more than one, but up until recently it was only one that was selling it. It's called Humira, which you may have seen an advertisement on TV for this. Humira, in fact, is the #1 selling pharmaceutical drug in the world in terms of monetary value of sales. It is not cheap, but it can be quite effective. And you don't have to take it every day. These are injections that are done, I think, once a month. Okay, the last type of arthritis that I'm going to talk about is, and these are the last two slides here, last type is gout or gouty arthritis. This is due to, remember that the body normally produces nitrogen waste metabolic products as urea, and it's excreted in the urine. But the body can produce some ammonia, which is toxic. Small amounts are produced, and small amounts of uric acid is also produced. Now, normally, most people don't produce that much uric acid, but some individuals produce more. Unfortunately, unlike urea, which is very water soluble, uric acid is not. It crystallizes and it deposits in joints and can deposit in some soft tissue, but typically when it deposits in a joint, it will cause a tremendous inflammatory response and tremendous pain. Typically, the joint affected is at the base of the large toe, and it's very painful. The typical description of a patient with gout is that states that they can't even tolerate the pain of the weight of a sheet lying on top of their toe as they lie in bed on their back. If untreated, the ends of the bones confuse and immobilize the joint. It can be very, very painful, but it is quite treatable with non-steroidal anti-inflammatory drugs or glucocorticoids. Colchicine is used quite effectively as a treatment. It's an inflammatory process that can come and go throughout a person's life, actually. And here we have the last slide, which is, covers what hasn't been covered in totally several topics in a completely superficial way, but here we go. Synovial joints resemble actually adult joints when the developing embryo is only at week 8. By that time you already have synovial joints that have the different structures in them. Only after 8 weeks, barely 2 months of development. Normally, very few problems occur with joints until late middle age, and then advancing years are always typically associated with problems. The ligaments and tendons will shorten and weaken. They become more fragile, in fact. Discs between the invertebrae are more likely to herniate. They're more likely to bulge out, and that's not good. If you look at almost, and not everyone, some people are lucky, but most people by the time they hit their 70s will have some degree, some involvement, or some of their joints will have osteoarthritis. Exercise is a tremendous way of postponing problems with joints because it strengthens many muscles in the body. You're using most of your body joints and strengthening the muscles, and it's not a weight-bearing kind of support because the water gives buoyancy, so you're not putting a lot of stress on the joints or the articular cartilage in any way. It allows you to move your joints, through thoroughly and not impact them, and therefore by using the full range of motion, and strengthening the muscle, you can often reduce problems of aging and joint problems. And that's the end of Unit 5A.